Hello, and welcome to the CAP Today webinar for Wednesday, October 19th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentations. Today's webinar is entitled Enabling Precision Oncology Care Through Collaboration. Testing before treating ERB2 HER2 alterations in metastatic non-small cell lung cancer. Today's very important webinar is made possible by a special educational grant from Thermo Fisher Scientific. We want to acknowledge this grant and thank them for their help in presenting this very important webinar for you. And I want you also to know that we're joined by representatives of Spectrum Pharmaceuticals, of which you'll hear much more in the future, as they're an important partner in this clinical condition. Today's speakers, and I'll say more about them in due course, are Dr. Salvatore Priore of the University of Pennsylvania Perelman School of Medicine in Philadelphia, and Dr. Narjust Duma of the Dana-Farber Cancer Institute in Boston. But before we begin formally, I do want to share a few tips for your greater enjoyment of today's program. First, we often suggest you refresh your browser. Please note in the lower right-hand corner of your computer screen we have a toll-free number, and there's live aid that will be available throughout today's webinar. That number is 858-345-5916. And also you'll see below the slides a box labeled Q&A. If you have any technical needs and need help with a matter regarding the website or the audio, you can also make a question or comment there. And again, live aid will be immediately at your beck and call. But of course, that Q&A box is principally for your comments and questions, which you can type in at any time during today's webinar. And after the presentations are over, I will triage all those comments and questions throughout the hour and then address our very distinguished presenters with those questions and comments for their answers. You'll get the full slides and audio should be posted in about a week at captodayonline.com. So you can share this with colleagues, you can review, you can refresh, and that's proved to be very popular, so I recommend it. I also want you to know you may see some follow-up email from us, also from our sponsor, Thermo Fisher, and I wanted to let you know that so you won't be too surprised. And finally, my last item, as always, I need to remind you that CAP Today does not endorse any product or service that may be mentioned in the webinar today, and any comments of mine are purely personal and not to be taken as the policy of CAP Today or the College of American Pathologists. And so now we're ready to begin. Our first speaker, as I mentioned, is Dr. Salvatore Priore. He's an MD and a PhD. He got those degrees at the University of Rochester. He's at the University of Pennsylvania Perelman School of Medicine as a molecular pathologist, and I will invite him to begin his presentation now. Dr. Priore.
Thank you so much for the introduction, and it's a pleasure to be here today to talk a little bit about identifying targetable variants in non-small cell lung cancer, especially ERBB2/HER2. So with that, I have a couple disclosures here. And the outline for today's talk is to really just kind of give a brief overview of the classification of non-small cell lung cancer, talk about the biomarkers that we find in non-small cell lung cancer that are important for appropriate patient management, and then talk a little bit more in depth about ERBB2/HER2 and testing strategies for that, and to sort of point out, how the laboratory, the molecular laboratory, clinical oncologists work together to make sure that this important information gets to the patient so that they can get the treatment that they need. All right, So cancer classification can be thought of at several different levels. The most broad level is you can think about classifying cancers based on the organ that it arises from. So when we think about tumors of the lung, we can call those lung primaries. But it doesn't give you a whole lot of information about, what exactly is going on with the tumor. A more refined view is to take a sample of that tissue, look at it under the microscope, and classify it based on its appearance, so its subtype. And these pictures in the middle show you major subtypes for non-small cell lung cancer, including squamous cell carcinoma, adenocarcinoma, and small cell carcinoma of the lung. Even a more refined view of cancer is to look at actually the molecular changes or the changes at the DNA level that are driving the formation of the cancer. And so this is just showing some common changes that you find in non-small cell lung cancer. So again, this is showing sort of in a graphical way what I just showed on the previous slide, but you can roughly group lung cancer into small cell lung cancer, non-small cell lung cancer, and of the non-small cell lung cancers, you have two big groups, squamous cell carcinoma and non-squamous. That red portion of the pie chart encompasses a lot, and mostly adenocarcinomas of the lung. And then the pie chart all the way on the right, you can see that from that group of non-squamous, non-small cell lung cancers, there's a huge variety of changes that are happening at the DNA level to subdivide these lung cancers into specific molecular groups. And here's a little bit more of a refined look at that, and you can see the key genes that are involved and their relative incidence in non-small cell lung cancer. And just to point out that ERBB2 HER2 represents a portion of this pie and is highlighted in yellow there, and along with a bunch of other variants that we see in non-small cell lung cancer, really creates a very heterogeneous disease from a molecular standpoint. So why do we classify these things? It's not just for curiosity. The molecular implications of these different drivers in non-small cell lung cancers have real practical implications for the patient. And this is just sort of a brief summary of the biomarkers that are found in non-small cell lung cancer and FDA-approved therapies. FDA-approved therapies that are associated with them. So you can see that since 2003, there was not so much progress, but then in the last 10 years or so, this space has really kind of exploded in terms of the amount of FDA approvals that are available and the amount of changes that are targetable by FDA therapies. And in addition to that, our testing strategy for identifying these variants has also changed, and I'll talk about that a little bit more. So because of all these recent approvals in the last few years for different molecular changes in lung cancer, professional guidelines have been updated to reflect the need to test these changes in our patients. So this just gives you sort of an overview of the current NCCN guidelines for advanced non-squamous non-small cell lung cancer. You can see under molecular testing, there's a variety. So under molecular testing, there's a wide variety of genes that need to be tested. And then there's also some additional biomarkers that aren't tested by molecular methods, but immunohistochemistry for PD-L1. So one of the things that I think is lost in like a figure like this is that it doesn't really convey the complexity of the molecular landscape that we encounter in non-small cell lung cancer. So this figure shows that when we talk about variants, we're really talking not about one mutation, but several different classes of mutations. So multiple genes and multiple different types of alteration. So single nucleotide variants are variants where you change one nucleotide in the DNA, which usually results in a change to the protein at a specific amino acid. Indels are insertions and deletions, which either insert or delete content in the DNA. And then fusions actually bring pieces of DNA from different parts of the genome together to create new genes and fusion products. And then copy number variants are increased numbers of the genes that are present in the genome. So this all sort of adds up to making biomarker testing in non-small cell lung cancer challenging because it encompasses all of these genes and all of these different variant classes. And the variant incidence is quite variable across patient populations. So for instance, EGFR exon 19 deletions are enriched for patients that have a never smoker or a light smoker history, where KRAS, for instance, is more common in patients that are smokers. And the number of FDA-approved targets continues to expand, and there's multiple molecular techniques that can be used to identify these. So you can think about PCR, FISH, and next-generation sequencing, and all of these have different advantages and drawbacks, and we'll talk a little bit more about that. Okay, so focusing in a little bit more on ERBB2, HER2 alterations, they're similar to sort of the broad set of variants that I just presented on the last slide, in that they fall into multiple variance classes. HER2 amplification and HER2 overexpression are probably more familiar to most people because they're very common and tested routinely for cancers like breast and gastric cancer. You know, when we talk about lung cancer, we're really talking about a different set of ERBB2 mutations, which kind of focus on single nucleotide variants and insertions and deletions. Okay. This is a graph from OncoKB, which is an online database that shows different distributions of variants in non-small cell lung cancer. And this just shows you that there's a variety of changes that occur across the protein and that they occur in several different cancers, including non-small cell lung cancers. All right, so the function of ERBB2 is kind of important to think about exactly where you see the different types of mutations in this gene. So it's a member of the ERBB family. It's a receptor tyrosine kinase that sits on the cell surface, and it doesn't have its own ligand, but it dimerizes with other ERBB2 receptors on the cell surface to signal through several other downstream signaling molecules, which causes the cell to proliferate and causes it to differentiate into a tumor. And this gives a little bit more granular view of that. So you can see the protein is divided up into an extracellular domain, transmembrane domain, and a kinase domain. And this gives you the distribution of ERBB2 mutations in non-small cell lung cancer, the majority of which occur in the tyrosine kinase domain in exon 20, and a smaller proportion occurring in the extracellular domain that's outside of the cell. And this also kind of summarizes where the major therapies against ERBB2 are targeted. Some of the tyrosine kinase inhibitors that are listed here are specifically targeting the tyrosine kinase domain, while some of these antibodies target the outside extracellular domain. Okay, glad to hear the audio is better. All right, so, how do we go from, a patient presenting to getting them the results that they need about biomarkers like ERBB2? So a patient usually presents with symptoms, cancer is suspected, a sample is collected, it is sent to pathology, and they confirm the diagnosis by looking at the tissue under the microscope. Then it undergoes molecular testing and PD-L1 immunohistochemistry, and aggregating all this information allows the oncologist, and Dr. Flores will talk about this more in her portion, to decide what the most appropriate first-line therapy is for the patient. And just to note, usually IHC is a quick turnaround test. Molecular testing can be a longer turnaround test, and so sometimes, you need to wait for all the results to be available before you can make a treatment decision for the patient. A lot of things have to happen in coordination to go from a tissue sample to a molecular result. The tissue needs to be procured either by an interventional pulmonologist or an interventional radiologist usually. It needs to be sent to the pathology lab where it's processed. In a lot of cases, it needs to be embedded and sectioned into slides and then stained. And then, IHC like PD-L1 and other IHC to classify the tumor are done. And then you reach a histopathology diagnosis of non-small cell lung cancer. And before you can send tissue for molecular analysis, there needs to be an assessment of the tissue adequacy. Is the tissue sufficient? Does it have enough tumor? Is there enough quantity for to meet the input requirements of the molecular assay? And then each lab has different setups in terms of what technology they use to assess the different variants that occur in non-small cell lung cancer. And they can encompass a wide variety of technologies, including PCR, next generation sequencing, and fluorescence in situ hybridization. So I just want to talk through briefly, some of the considerations about tissue samples and biomarker testing. When we talk about tissue samples, actually biopsying the lesion itself, this is the preferred sample type for testing. It's considered the gold standard, and it's part of the established diagnostic workflow. But there's several types of tissue samples. You can get a fine needle aspiration, core biopsies, fresh tissue or fluid from pleural fluid, for example. And each of these have different testing considerations in terms of the quantity of tumor cells that you can get out and the quality of the DNA that results from that. And that sort of can dictate what type of testing you can accomplish from each tissue type. Some other tissue types or some other sample types that some of you may be familiar with is the idea of a liquid biopsy where patients actually just get a blood draw, and the target of that is just tumor DNA that's circulating in the patient's blood. And it has some advantages because it's pretty non-invasive. It's just a blood draw, and it's particularly advantageous when the patient has a lesion or a tumor that isn't amenable to biopsy. However, it requires that sufficient quantities of tumor DNA be circulating for the test to detect it. And so if you get a negative result, you're going to have to follow up with confirmatory testing on a tissue. So very briefly, this is one slide that probably could be an hour-long talk in itself in terms of deciding which molecular method to use for mutation detection. And so I just sort of very briefly summarized it into two broad categories. PCR, or another way we can think about it is sort of single analyte or few analyte testing, few gene or few mutation testing, and then next generation sequencing, which is a little bit more comprehensive, covers a lot more genes. So some of the advantages of PCR, most molecular laboratories will have the instrumentation in their labs to do this, relatively low cost. But again, if you're testing multiple targets, that cost is linear and adds up for each target that you add on. And it's familiar technology. Most people are used to PCR reactions, and the interpretation and validation of those are a little bit more straightforward. It's limited to well-characterized gene regions and mutations. If you're doing multiple tests sequentially, that's actually going to use a lot more tissue than doing something in a parallel fashion. And it can't detect non-specific mutations that the test isn't designed to detect. But that's true of any molecular assay. NGS, on the other hand, can identify a variety of mutations in target regions. I just want to put a caveat here that, variant identification can vary between NGS panels and tests. And so you have to be careful to look and make sure that you understand what the test is actually covering and what its capabilities are. While most NGS tests can, reliably detect single nucleotide variants and indels, you have to be careful to make sure that it can also detect other variant classes that you might be interested in, depending on the specific change you're looking for, like fusion transcripts or copy number changes. So, the timing of this is usually a little bit longer than PCR. The cost is usually a little bit higher on a per sample basis. But if you're talking about analyzing multiple targets and multiple genes, the cost savings really adds up. And so this is why this has become sort of a preferred or common method for doing comprehensive genomic profiling for patients with non-small cell lung cancer. And just to sort of finish my portion of the talk, I wanted to present real data from my next generation sequencing practice. And this sort of grounds me and keeps me excited, and this is what really motivates me. This is data from a real patient where we identified an ERBB2 exon 20 insertion, and that's highlighted here by this purple box in their DNA sequencing reads. This is a 9 base pair insertion there. And so, I always am excited when I see these because I know that there's real tangible benefit to the patients that are going to receive these results. All right, so in summary, non-small cell lung cancer is a very heterogeneous disease. Driver mutations in a variety of different genes spanning several types of variant classes, including single nucleotide variants, insertions, deletions, fusions, and copy numbers. The number of targetable genomic variants with FDA-approved therapies has increased steadily over the last decade. ERBB2, HER2, in particular, exon 20 insertions, are an important biomarker for non-small cell lung cancer and have been getting a lot more attention lately. Many techniques exist to identify genomic variants, including PCR, NGS, FISH, and just remember, they all have trade-offs in terms of their cost, the quality, and the speed at which they can deliver results. And this precision oncology really requires the coordination of a lot of different healthcare providers to effectively get the data to the patient. So you have to effectively get tissue that's adequate for testing. You have to have an anatomic pathologist establish the diagnosis and assess the tissue for molecular testing adequacy. A molecular pathologist who can set up these assays in the lab, test the samples, and interpret the data. And then clinical oncologists and advanced practice providers who take those results and oversee the personalized treatment for the patient. So with that, thank you for your attention, and I will hand it back over to Bob.
Dr. Priore, thank you very much for that wonderful lecture, and thank you, too, for your patience with us, with whatever audio problems seem to erupt on some external phone lines. And I also want to thank the audience for hanging in there with us so perfectly well. We'll be sure once we post the slides and audio that all of that has been taken care of and will sound much better when we put it up in approximately 1 week on captodayonline.com. Also, I want to urge everyone, if you have a comment or have a question for Dr. Priore or our next speaker, Dr. Flores, go ahead and put that in the Q&A box, type that in, and we'll get to that, those questions and comments after our second lecture, which is just about to begin, and that will be given by Dr. Narjust Flores. She's the Associate Director of the Cancer Care Equity Program, very hot topic, as you know. She's a thoracic oncologist at the Lowe Center for Thoracic Oncology, an Associate Editor of JAMA Oncology, at the Dana-Farber Cancer Institute of the Harvard Medical School. I want you to know that she trained at the Mayo Clinic, and so her educational credentials are top-notch, and I'm very, very eager to hear her lecture. Dr. Flores.
Hi, everyone. Can you hear me well? That's the first question.
Yes, I can hear you.
Okay. I'm using these fancy headphones. Hopefully they work.
Okay.
I'm happy to be here. I do have to give a shout out. I think my sister, Dr. Pantoja, is on the line. So this is the first time I'm giving a presentation where my sister is listening to me. So the standards are a little bit higher right now.
Right. Wonderful.
We're going to talk about why is this important, why understanding HER2 is important, and how all the testing you do will help me in the clinic to treat these patients, and what are the unique things about these patients as well, because they have a genotype and they have a phenotype. I specialize in women with lung cancer. HER2 mutations are more common in women. These are my disclosures, and this is the outline that we're going to be breaking down. So lung cancer has changed. It is not what it used to be, that our patients will live 6 months and we only have carbotaxol. No anymore. Now we are breaking down our lung cancer by molecular type and by PD-L1 expression. Things are changing. I have patients that are living 11 years out from the diagnosis of lung cancer. And that is thanks to targeted therapy. So I'm going to present one patient I saw in clinic. She's a 57-year-old woman with no smoking history. She presented with back pain and shortness of breath. Fast forward, she was diagnosed with metastatic lung cancer. The NGS panel showed that she had a HER2 exon 20 insertion. Her PD-L1 was less than 1%, which we usually see in these patients. She received first-line therapy with immunotherapy and chemotherapy, but as expected, patients unfortunately will develop progression. Most of my patients, I say all of my patients, get tested for any molecular markers, particularly patients that don't have a smoking history. The probability of having a target mutation is very high. I also, to respond live, the Q&A question, a lot of my patients at the time of disease progression, I also do sequencing because the disease will evolve as you continue to expose them, not only for HER2 therapy, but for any lung cancers. They develop alternative pathways and resistant mechanisms. And a way to learn resistance is to biopsy at the time of progression. So this patient, we have targeted therapy. The patient we talk about it. She went in HER2-directed therapy. I saw her 2 weeks ago. She's doing good. She's taking care of her new grandchildren. Like she has twin boys that were born. Thanks to targeted therapy, thanks to testing. But I want to show the other side of the story. This is a patient that I saw in my previous position. 42-year-old female, very remote smoking history in college. And to be honest, if you ask a patient, most of them have some type of smoking history in college. Diagnosed with lung cancer, she was started in carboplatin, pemetrexed, and pembrolizumab, same therapy than my other patient, and then followed by docetaxel and gemcitabine. The difference between this patient and the other patient is that this patient did not get molecular testing. She came to see me as a second opinion, and I was able to do sequencing at that time, and she was HER2 positive. The problem is that when I saw her, her performance status was a 3. That means she needed assistance with activities of daily living. She was not able to dress herself, feed herself. So she couldn't reach the targeted therapy because she was too sick for that. And she unfortunately passed away around 4 weeks after we met. So that is the importance of targeted therapy. While my patient that's in HER2-directed therapy is spending time with her grandchildren older than this patient did not have the opportunity to live longer because testing wasn't done. And that's what is so important. So another thing, the importance about tailored treatment is that this is the overall survival data that shows that patients that, this is for EGFR, that go in targeted therapy, they live significantly longer. But not only about living significantly longer, it's also about the quality of life. Chemotherapy remains being a toxic drug. They're toxic compounds. They have toxic side effects, and they're accumulative. The more chemo you get, the more side effects you get. So in my patients with targeted therapy, I can tell you I have 2 patients with metastatic lung cancer run the Boston Marathon this year. 2 of them with metastatic lung cancer thanks to targeted therapy. I don't run. I'm not able to run when my patients are running. But thanks to targeted therapy, I was able to be at the finish line we assigned, supporting them. You saw this pie chart, and I think it's very hard to talk about targeted therapy in lung cancer without showing this pie chart. 52% of patients with non-squamous, non-small cell lung cancer, we have an actionable mutation. And on the other side, you can see the drugs that are approved. We don't only have 1 drug, we're having 2, and in the case of ALK, we're having 5 drugs approved for these mutations. And there are more down the pipeline. There's NRG1, there's CA, there's new. So I hope that when we meet again, this pie chart will be all the way to 60%. So we're talking about HER2, and this is the algorithm for HER2. It tends to be as common as ROS1, so it's 1 to 2% of lung cancers. But when you hear 1 to 2%, you may hear like it's not a lot. But there's around 150 to 170 new cases of lung cancer a year. The majority are diagnosed in stage 4, particularly for younger women, young women with no cancer diagnosis. Those patients tend to be diagnosed at later stages because it's believed that they cannot have lung cancer. So this is a summary of who should get tested. I think all patients that are non-squamous should have NGS testing or target panel, whatever is available. For a squamous, I tend to have young patients that are non-smokers that have a squamous histology. If you have a very questionable sample size or you have a adenosquamous histology. I also do EGFR testing for stage 3 patients who are going to get chemoradiation. And now we need adjuvant therapy. We're pretty much doing NGS testing from stage 1B to stage 4 and non-squamous. All right, so testing, what should we do? NGS testing or liquid biopsy? Both of them are complementary for me. Around 50% of my patients are second opinion. And we were talking about this. And often spend a lot of time trying to target the tissue. Getting a tissue biopsy for lung is not as easy that for breast or for colon, right? I told my patients, you have a target that continues to move and we need to put a needle in your lung. We are risk or pneumothorax. So I can spend time trying to target the tissue, and I supplement with circulating tumor DNA or liquid biopsy to try to accelerate the process in some of these patients that come for second opinion. Now we have better approval and we have coverage. I do have an internal next-gene sequencing profile at my institution that makes the turnaround time faster. And why is this important? It's very anxiety-provoking. When you tell a patient you have metastatic lung cancer, now we have to wait. It is very anxiety-provoking. If the patient is symptomatic, we can do a cycle of chemo, but we like to avoid that if possible in patients that are overall stable. But the issue with the liquid biopsy is that if you have a liquid biopsy that's negative, that doesn't mean you don't have a mutation. Some tumors are very low shredding. Let me give you an example. This is particularly unique to HER2. Patients tend to have brain metastasis. It's very trophic for the brain. So the patient can have nominal brain metastasis and a lone primary, and we'll not find shredding DNA in the liquid biopsy. So that doesn't mean the patient doesn't have the mutation. It's just we couldn't find the circulated tumor DNA. And that's what I explain to my patients. A negative liquid biopsy doesn't mean you don't have the mutation, especially in patients with oligometastatic disease. So HER2, and Dr. Priore just break this down in more detail. I'm not a pathologist, but I think it's very important for all of us to understand that not all HER2 are the same, not all HER2 alterations. We have the mutations, 1 to 4%, the gene amplification, and the protein overexpression. So the mutations are usually in exon 20, and I'm going to say this probably 7 times. HER2 alterations in exon 20 are not the same that EGFR exon 20 insertions. There's an exon 20 location, but it's not the same culprit. So mostly are exon 20 in-friend insertions, mostly in never smokers, but some patients, around 25% of them can have a smoking history. So a smoking history should not be a reason why this patient should not get tested. Remember that the early patient, she smoked in college, she had a HER2 mutation. Prior to targeted therapy, prior to the approval, which is, I believe by now is 5 weeks old, as the HER2 therapy was approved 5 weeks ago, they had a worse prognosis. But now we have targeted therapy in this setting. Here's the breakdown. This is a study that was done in like a group of cases by Memorial, and the median age of these patients can range between around 50 to 65. So they are a little bit younger than the traditional patients with lung cancer. And I say I was going to say it 7 times. HER2 exon 20 is not the same that EGFR exon 20. It's just location, different situation. So the HER2 mutant cancer is not the same that the HER2 breast cancer either, because in terms of HER2 amplification, breast cancer HER2 is seen as a oncodriver mutation and can be seen this. In lung cancer, the amplification has not been linked to response to therapy. So not the same with breast cancer, not the same with EGFR. And it can become confusing as we keep talking about more and more cell locations, different gene, same gene, different disease. For these patients, if they have a co-mutation with P53, that's usually unfavorable diagnosis. And why I mention this? Because this brings attention to the importance of next gene sequencing. Next gene sequencing helps you understand other mutations that do not have FDA-approved therapies. And it helps you to classify patients as several risk factors and also gives you options for potential clinical trials. We are seeing more and more clinical trials that are evaluating mutations we call mutations, like P53 and STK11, for example. So, we found that HER2-directed therapy in breast cancer is great. So obviously, lung cancer oncologists like me thought, oh, well, we can just use the HER2-directed therapies that we're using in breast cancer for a long time. One of my close patients and collaborators has been in HER2-directed therapy for breast cancer for 10 years. So I was like, it makes sense. Well, it didn't. So we tried to add chemotherapy to trastuzumab in patients with HER2-positive lung cancer, and it was a negative trial. So we needed to reconvene and think again, because trying to translate the information from breast cancer did not yield the same results for lung cancer. So what do we do for HER2? Well, at this time, we have approved therapy in the second-line setting. First-line setting, these patients get a combination of chemo plus immunotherapy. That's the standard treatment. It comes from the trial Keynote 189 that shows that this is the best outcome. But just fresh out of the oven, we have a drug approved in August 11, exactly 5 weeks. And this comes from the Destiny Lung 2 trial. I have experience using this drug because I enroll patients into this trial. So this is trastuzumab deruxtecan. This is a drug conjugate, and it was administered to 91 patients, a small sample, that show a progression-free survival of around 8 months, overall survival around 18 months. But patients with amplification and overexpression were not included in the trial, and this is very important. So we talk about the duration of the response and the objective response rate. One of the challenges with this approval is the toxicity. And it's again a reminder that we cannot translate data from breast cancer to treat lung cancer. Patients that are going on trastuzumab deruxtecan that have lung cancer tend to have more toxicity in the lungs. And you can see here 46% of patients had grade 3, which means affecting their daily quality of life, or higher in this drug. So this drug conjugate is an antibody that is linked to chemotherapy. I find it extremely fascinating, and sorry if it's boring, but the antibody goes to the cell that's HER2 in the lung and delivers the payload, which is the topoisomerase inhibitor or the chemotherapy. But compared to breast cancer, where is this payload being delivered? In the lung. And the majority complications tends to be pneumonitis. And it's a significant side effect that needs to be followed. So toxicities, we talk about pneumonitis or interstitial lung disease. It happened in 26 patients, and 2% of the patients enrolled die of complications for ILD. Other side effects are commonly as known, nausea, fatigue. I always tell my patients that cancer therapy is a trade-off. We trade off response, longer survival for side effects. I still don't have the first cancer drug that doesn't have at least 5 side effects or more. But one I wanted to start with here is that we are not doing well with recommended testing. Another for me to put patients in HER2-directed therapy, another for my patients to spend more time with their grandchildren, we need to do testing. And this is from 2021, so a year ago, that show for 5 biomarkers, and right now we have 9 biomarkers in lung cancer, only 49% of patients were being tested. Only 50%. So when I brought the story of my patient, at the beginning, people was like, oh, why that doesn't happen? That's so rare. 50% of patients did not get more than 5 biomarkers, or all 5 biomarkers. And this includes PD-L1, which it is not a target therapy biomarker, it's an immunotherapy biomarker. We are doing better over time, but we are still not testing a good chunk of patients. And these tends to be patients that are in rural areas or patients that have limited access. There are documented racial disparities when it comes to testing. This was presented a year ago as well. And African American with non-small cell lung cancer were tested 39% versus 50%. And so what is the consequences not being tested? First, you live less time, you don't get in the right therapy, and also reduces the chances of going in a clinical trial. And that's significant for the outcomes. If you don't get biomarker testing, it's very unlikely to go in a clinical trial that we provide you an option for not only therapies at first line, but therapies at second line and third line. Chemotherapy tends to be good for first line, but usually doesn't work for a long time. The progression-free survival in Keynote 189 was 12 months. Well, the progression-free survival in Flora, we keep putting names that are very common, Flora, Laura, Adora, in Flora was around 36 months. So everything is connected, biomarker testing and clinical trial participation. There are many issues with biomarker testing. I think enough tissue tends to be 25% of the cases. So tissue is still the issue, no meat, no tree. And the turnaround time tends to be a big issue. Most NGS takes longer than 2 weeks. And with the recent issues with weather, there were delays for testing for patients in Florida, for example. And also, who pays? Like, we can do reflex testing. A lot of institutions were doing this, and then they stopped doing it because of the issues with reimbursement. So we need to make sure we all work together. I have 2 pathologists in a speed dial, my molecular pathologist, 2 pulmonologists, the surgeon, to make sure that we do testing pretty much for all non-squamous patients, because now patients are getting adjuvant target therapy. It is all our responsibility to get patients tested, especially for new markers like HER2. The drug was just approved five weeks ago, right? So we need to increase the awareness of testing for HER2 so patients can go on the right treatment. While HER2-directed therapy can be a little bit more toxic in lung cancer, it's still better than docetaxel. So I'm finishing here with the clinical takeaways. Biomarker testing is very important. Circulating tumor DNAs can supplement and help when tissue is not sufficient. But again, because HER2 is so new, we don't have a lot of data about HER2 and circulating tumor DNA. HER2 mutations are often found in exon 20, never smokers. But patients' smoking history should not exclude them for biomarker testing. For available agents, HER2 amplification overexpression doesn't seem to be a driver, and they don't seem to be responding to therapy. And we have this brand new approval for HER2-directed therapy. So I'm going to end here so we can address the questions. Is that okay, Bob?
Yes, that's very fine. Dr. Flores, I want to thank you for a wonderful presentation. It's so rich in issues in many, many directions, and I'm sure everyone on this call will be interested in reviewing and refreshing their acquaintance once we post the audio and slides. And the same is true for Dr. Priore. As a matter of fact, as you catch your breath, Dr. Flores, I'm going to ask the first question to Dr. Priore. There's a lot of interest, clearly, between HER2 in breast and HER2 in non-small cell lung cancer. That's only natural. Let me ask a question about FISH testing, though, to you, Dr. Priore. Do you see HER2 amplification by FISH in non-small cell lung cancer?
Thanks for the question. Yeah, as we showed, the types of alterations that you see in HER2 between breast cancer and non-small cell lung cancers are pretty distinct. And so what we're really targeting for non-small cell lung cancer and the variants that you see there are insertions and single nucleotide variants. So really those are the ones we're testing, and FISH does not really play a large role or any role in that in non-small cell lung cancer testing at this point.
Thank you very much. My next question I'll direct to Dr. Flores. Is there evidence that exon 20 insertions respond better than other known oncogenic ARBB2 variants such as hotspot single nucleotide variants?
So because those patients were not included in the trials, we don't really have any accurate data to see if they respond to HER2-directed therapy the same. So in early trials trying to evaluate some of the TKIs, tyrosine kinase inhibitors, show that these patients did not have the same response to these TKIs compared to the traditional, because come on, it's only 5 weeks old, to the other, the most common HER2 alteration in lung cancer.
Thank you. Let me ask you another question, which is on many people's minds. Dr. Flores, how do you explain the uptake in lung cancer that's been widely observed in younger women who are runners, younger women generally, and non-smokers?
So this is the focus of my lab. So the Flores lab focuses in understanding why younger women with lung cancer, why younger women are having more lung cancer. And let me back up for the percent of the people. In 2018, for the first time in history, younger women are getting more lung cancer than men. There is one study that was just recently presented in Vienna at the World Conference on Lung Cancer, and this is mostly because we know we see a lot of EGFR in Asia, but could be a relationship between EGFR mutations and pollution. That's something that is quite new and needs to be verified or confirmed, but that's one of the associations. Another data that has come out, some other from my lab, some other from University of Minnesota, is the hormonal exposures. We have estrogen receptors in the lung, and since 1950, when the pill was introduced, we have, more external estrogens women have received. So secondary to this data that came out of my lab in 2018, in 2021, we launched the epidemiology of young lung. This is a collaboration with Dr. Nieva and the Alchemy team. So we're interviewing younger women and men with lung cancer, and we're also interviewing their mothers to understand any exposures, because this is an epidemic that continues to get worse every year, and we need to find out what is happening. Like, I'm right now treating a 21-year-old that her goal is to finish her master's degree, and she will never imagine in her life that she will be dealing with metastatic lung cancer.
Thank you. Dr. Priore, would you care to comment on that very same question about this phenomenon of rising rates in younger women, non-smokers, etc.?
I don't have anything to add other than what Dr. Flores says. She's definitely the expert in that area.
Yes. Thank you very much. Let me now ask again, Dr. Flores, our next question. In your experience, Dr. Flores, can new mutations develop over time in a single tumor in this context of non-small cell lung cancer? And if so,
yes.
How often should sampling be done to ensure that a previously HER2 lung cancer has not developed mutations?
It is so there's two things. It's very hard to develop a de novo mutation after treatment. That is not commonly seen. A de novo target mutation. There are other resistant mutations that don't have target therapy yet that will develop over time. So it's very hard for a patient that was EGFR negative to become EGFR positive for the ones that we have drugs, because these are onco-driven mutations. It's very rare to have de novo HER2 after you were negative initially. I'm saying very hard. I never seen it, and I tend to sequence my patients a lot. I never seen it to have de novo, and we lost to Dr. Priore's input. Had you seen any de novo target mutations after the patient went in chemo or immunotherapy? I haven't seen it, but I'm not going to say no 100%.
Yeah, no, I was thinking the same thing and trying to think back to all the cases I've seen. Very rare to see, but ERBB2 also makes up such a small portion of the pie. I've never seen a post-treatment development of an ERBB2. Very, very rarely for EGFR positive patients. I have seen a few cases where, for instance, they'll develop an ALK fusion as a resistance mechanism, but that is very, very uncommon. So usually the types of resistance mutations you'd see develop in these tumors really have to do with escape mechanisms to the area that's being targeted. So for EGFR and ALK and ROS, what you see is point mutations or single nucleotide variant changes that sort of decrease the ability of the targeted therapy to bind to its to the area that it's designed to target.
And I just would like to add some, but can I add
Sure.
something quickly? I think the importance
Sure,
of the importance of sequencing patients after progression is to learn more, and that's a new practice. So I hope that, in a few years we have more information. The more information we know is about EGFR that has progressed on target therapy. There's always an alternative pathway. So we're seeing MET amplifications that we're trying to target right now in a clinical trial. So these are patients with EGFR that went on osimertinib, which is a irreversible inhibitor. Then they have disease progression. We sequence, and then we find the MET amplification. So we target one clone with the osimertinib, and then we target the MET with another target therapy. But that is only 15% of patients that are in osimertinib.
Right, and we do the same thing, and sometimes we actually test for MET amplification up front for EGFR positive patients because some of them have, resistance, primary resistance at diagnosis as well. So another reason why.
Go ahead. Okay, let me begin now to close with a general systemic kind of question around healthcare systems and where the organization of the care it would be optimal. And I have a very good question here for both of you. I'm going to ask Dr. Priore to take the first answer, and then obviously I want to hear from Dr. Flores. And the question is as follows. Would having NGS testing available within a health system with a large and growing oncology program be valuable? The concerns we've heard include building the appropriate library and in-house expertise and not having enough test volume to bring the test in-house. Now, you both represent extraordinarily great academic institutions, so I know you've got the NGS testing available, but what would you say to this question from one of your colleagues in a little different healthcare setting? Dr. Priore.
Yeah, that's a really loaded question for the last minute of the talk. This could be its own webinar in itself. I think there's a lot of considerations. Obviously I am biased by the environment that I am in, but I also think that there's objective data to show, and Dr. Flores mentioned this during her talk, about the ability of all the people putting the pieces together to be in one place and communicating with each other to make sure that the patient gets the right testing at the right time and the right treatment so they can maximize their quality of life and get the most benefit they can from treatment. That being said, setting up an NGS lab is not a trivial endeavor. It's expensive. It requires a lot of personnel, specialized pathologists who can validate the tests, and it's not very as simple as sort of plugging in an NGS machine and starting sequencing. NGS is actually under the discretion of CAP and CLIA, and so there's a whole bunch of regulatory requirements that you have to follow to set up a laboratory like this. And unfortunately, the landscape around coverage and reimbursement for NGS has become very complicated, and it's been sort of singled out and differentiated from other molecular techniques. So there's a lot of competing priorities in terms of, does the volume support it? Does the institutional strategic initiative support it? Is there the resources available to deploy it effectively and safely? And so those aren't easy questions to answer, and it's a case-by-case consideration. I will offer the Association of Molecular Pathology offers kind of a quick laboratory management course on their website for free that talks about some of those issues and thinking about return on investment and setting up molecular testing at an institution. So some of those resources might be helpful for individual institutions to consider what the right testing strategy is for them.
Yes, thank you very much. That's an excellent answer. And Dr. Flores, you mentioned in the course of your talk you see an enormous amount of patient referrals, but I'd be interested in your answer to this question as well. Having NGS testing available within a health system, regardless of size and specialty.
I think, what Dr. Priore mentioned is true. I used to practice at the University of Wisconsin, and I was at Mayo. So I know what the rural setting limitations are out there. I think more than the setting the lab, it would be creating an effective workflow to work with external labs. I think the effective workflow and to make sure we count biomarker testing in lung cancer as we count hormonal status in breast cancer is very important. That is essential for treatment. you won't let me put this in perspective, and nothing against breast cancer, to be clear. Nobody reports breast cancer as breast cancer. Everybody reports it in the pathology report by the hormonal status. So we should do the same for lung cancer, that we should not say lung cancer. This is a ALK-positive non-small cell lung cancer, right? Like we say estrogen. So I think an effective workflow is where I will put more of my effort instead of to creating a full lab, because, inventing the wheel again, but working with an external lab could be a way to get the testing that you need.
Very good. That's a wonderful, excellent insight, and I want to thank you for that. This has really been a magnificent program, and so I'm going to leave you with the last word, Dr. Flores, and I want to wind up here. I want to thank Dr. Salvatore Priore of the University of Pennsylvania, and I want to thank Dr. Narjust Flores of the Dana-Farber for excellent presentations, very enlightening, and very worth study and restudy. I want to very much thank Thermo Fisher Scientific for their special educational grant for this program, and I want to thank Spectrum Pharmaceuticals for their participation and presence here. It's very important to us. And finally, I want to thank all of you who have taken time out of a very busy schedule to join us today. So once again, thanks to Dr. Priore, Dr. Flores, Thermo Fisher, Spectrum Pharmaceuticals, and all of you. And with that, I'll bring today's webinar to a close. Thank you very much.